thank you for inviting me to this session. A year ago, I gave a previous talk to the Foundation Trust Governors, and I recognise some of you, so some of you were there. I had a really good time. We had some really interesting debates. So what I'm going to do this afternoon is talk for a while, but I'll leave plenty of time to hear your views. And I would very much value your views on your role and how it relates to our role in the CQC. So think about what you want to discuss and questions as I talk through, but I'll give you some background to my role and the role of the CQC in looking at quality in organisations across the NHS and where we think we're going. And I welcome your views on that as well. So just the Francis report was a real shock for people like me who've been working in the NHS for many, many years. And there have been other reports, the Bray report is here as well. There's a real sense that the NHS, if you like, had lost its way to some extent. And Francis said, and it was really resonated very strongly with me, that there was a problem with the NHS culture. The NHS needed a new culture. And so I went into the CQC, and the CQC's programme at the moment is about inspecting, regulating, but it's also about trying to change culture, trying to change the culture for the better, and address some of those concerns that came through the Francis report and others. And part of that was setting up the new comprehensive inspection programme. Our old inspection programme was heavily criticised as being superficial, inexpert, and so a new programme was set up by Mike Richards, and I thought it looked such a powerful way of taking things forward. I decided I would leave the trust where I'd been for 4 years and join the CQC to be part of the team driving this forward. Many of you will have been inspected. Most of you will have been inspected because we've done now all the acute hospitals. We are just finishing off the mental health trusts, ambulance trusts and community trusts at present. We'll have them all done by the end of June. So if your trust hasn't yet been inspected, it will be very shortly. And these teams have specialist inspectors, clinical experts. There's an element of peer review in them. And we call them comprehensive, but we focus on a series of core services. So we're looking at the same thing in every organisation. And one of the most powerful things is that we look at quality in terms of 5 key questions, which you've probably heard of, but just to reiterate, we ask, are services safe? And that is, do they protect patients from harm, avoidable harm, and do they protect patients from abuse? So safety has a wide definition. Are they effective? Do they achieve good outcomes for patients? Are they caring? Is the interaction between patients and staff positive, compassionate? Is patients' dignity protected? Are they responsive? Do they meet the needs of patients and different patient groups? And then finally, are they well-led? And well-led was a new innovation here, but actually has been extremely powerful, and we've come to recognise how important leadership is in determining quality of trusts, and I'll come back to that. One of the things that has really taken me by surprise on the inspections, and I've done quite a few face-to-face myself, is how willing staff are to talk about their genuine concerns and what's holding them back providing the best care for patients. And that honest voice of staff has been very powerful in driving our inspection findings. And it's a very important one. And one of the things that really worried me was that why is it that I and other executive members of boards in the past have not heard that voice so honestly? Because I know very well when you listen to staff as a member of the management team, you tend to hear a filtered view. Staff tell you what they think you want to hear. While you go in the CQC, they tell you what they think you ought to hear. And I think getting that communication with staff is one of the key things to improving the culture and ensuring quality of care. We provide ratings, and I'll come back to that, but the ratings are not there to apportion blame. One of the things we're very keen on, we do not want to add to the blame culture in the NHS. It's full of blame already. People are always looking for someone else to blame for when things go wrong. We don't want to be part of that. We want to create honesty about what the problems are, but not blame. And so I think you will often hear people saying the CQC is blaming this, that and the other for problems. We're not. We're just saying this honestly is what the situation is. Let's all work together to solve the problems. And we want our inspections to drive quality improvement, and that's very, very important. They're not there just to tell people off. They're there to help people make things better. And actually, we've got plenty of evidence already that of the inspections we've done so far, they've been important drivers in improving quality of care across the trusts we've inspected. So this is a kind of ratings grid. If you've been inspected, you'll have one of these. And these are the core services down the left-hand side of that. This is an acute trust, so it's things like A&E, medicine. And those are the 5 questions across the top. And for every core service, for every question, we give a rating, and we aggregate those up for a rating for the trust as a whole, which bottom right-hand corner here is good in this regard. And this is a very typical, very good trust. This trust is consistently green, is coming out overall good. It really is a very good trust indeed. This compares to a trust where we found significant problems, and here we found problems in A&E, where we found inadequate for safety, responsive and leadership, and in surgery, and those aggregate up to produce an overall rating of inadequate. So we look at the detail in each service for each question to produce the overall rating. We don't just go in and say this looks like an inadequate organisation. We say it's inadequate because of problems in A&E and surgery. So there's a lot of detail in the reports behind those ratings. And these organisations are having the most detailed quality audit that they have ever had. And the detail in the reports is, I think, really a very important resource for them. And I hope for you in your role as well. And just in comparison, this is a trust that came out as outstanding. And you see they have consistently achieved outstanding in several categories. And I'm very glad to say that we announced our 3rd outstanding trust today, and I think it's already been announced and cheered, so I won't call for a cheer, but well done, West Sussex. We are very pleased whenever we can give a trust an accolade of outstanding. It is a great achievement, particularly in the NHS, as it currently is with all the pressures you're working under. So overall, some overall messages about what we've found. There's a marked variation in quality. On the left-hand side here, you see the kind of overall ratings for most of the trusts we've inspected so far, and you'll see there's enormous variation between those at the top in the outstanding category and those lower down with more problems. But most importantly, there is usually a marked variation within trusts. There are often poor services in good trusts and occasionally outstanding services in inadequate trusts. And so there's not a consistency of quality. So when we say a trust is inadequate, we aren't saying every service in it is inadequate. As I've said, it's about specific areas and specific focus points. Management is very much about the day-to-day. It's about getting through to the end of the week, getting through to the end of the financial year. We don't see nearly enough long-term planning. When we go into A&Es, for instance, they're often working under enormous pressure. But it's pressure that could have been predicted. Every year, the number of attendances at A&Es goes up. Now, that may be something that we feel should not be happening, and those patients should be treated elsewhere. That's another issue. But the hospital can predict that is what's going to happen and needs to be planning ahead to meet that demand in a safe way, within the resources it's got. But sometimes we go into an A&E and get a sense of complete learned helplessness. What can we do? The patients keep coming. And I think that crisis management culture is something that we need to challenge. Staffing is still a concern in some areas, but much less so. Most hospitals responded to Francis very positively by reviewing their staffing and improving it. We still find some areas, but it's not the big issue it was at the time of the Francis report. And every hospital will tell us they are safe, and safety is their first priority. We have a presentation from the Chief Executive on day one, and the Chief Executive almost always says safety is our top priority. And then you walk into the hospital and you find things are not right. Fire doors are blocked, resuscitation trolleys are not checked, staff don't have their mandatory training. And so there's a distinction between the rhetoric and the reality. And I think that's something we want to challenge as well. And also the systems of risk management and quality assurance are very variable. In some trusts they're very well developed, and they manage their risks very carefully and use risk management as a really active tool to make sure that services are safe. In others, it's tokenism. Here's our risk register. We last updated it a year ago. We haven't looked at it since. But, here's the paper evidence that we're doing risk management. Quality assurance, quality audits should be going on, and there should be quality improvement. A service is not high quality unless it is seeking every day to improve its quality. Quality improvement is part of that. And you see some services have given up trying to improve quality because, again, that issue of learned helplessness. So the overall ratings for acute trusts, I won't go through this in detail, 63% at the moment are coming out as requires improvement, 25% good, 2%, although that will have gone up today, the slide predates today, are outstanding, and 10% inadequate. I think I mentioned the safety issue, and the leadership issue is very important as well. We've found a lot of trusts where there are significant leadership problems that need to be improved. And we don't mean the chief executive. Sometimes the problem is leadership at clinical team level. And one of the trusts need to make sure is that the matrons have the leadership skills, the clinical directors have the leadership skills. They are the leaders that make the real difference to patients. And the chief executive and the board's job is to make sure that leadership is really effective at clinical team level, not to try and run everything themselves, as sometimes we think. Blame and bullying. 24% of NHS staff in the last NHS staff survey say they feel bullied at work. 24%, that's nearly 1 in 4 staff. Now, how staff can operate in that environment to provide high-quality care, I think is questionable. For me, it is unacceptable that we are not supporting our staff better. But this is part of the culture that Francis says we have to change. And I think sometimes we go to trusts and they say we have real difficulty recruiting staff. It's the price of houses. It's the transport arrangements. And then you look at their staff survey and you see that their staff are having a miserable time at work. And you think, well, actually, may that have something to do with it? Not actually the kind of excuses that we're coming up with. Formal leadership, the board, but also informal leadership, senior consultants, the clinical academics, the people who actually have some of the power in the organisation but no official management role, are often in denial about the problems. They often say, actually we're really very good and every other hospital is as bad as we are, so how can you hold us out? But actually, they've often not been to see the other hospitals. We've declared some hospitals outstanding. Have they been to look at those hospitals, see what's different? So, this kind of sense of denial is really very important. What we have found is that some hospitals have really turned around dramatically after our reports. And those are the hospitals that accept the problems. Don't try and deny them. Don't try and explain them away. They accept the problems and see them as a real challenge to improve. And I think our reports have been really instrumental in some centres for doing that. Just quickly, for those of you with mental health trusts, we're finding similar findings. I think the striking thing about mental health trusts is, if you look at safety, 94% of mental health trusts that we've inspected so far requires improvement or inadequate for safety. And I think that is a real concern. It is a real concern. But broadly, in terms of overall ratings, the ratings are similar to the acute trusts. And community trusts as well. Again, we haven't got so many as yet. Broadly, the issues are the same, but leadership in community trusts seems to come out better than it does in acute trusts or mental health trusts. And again, that's based on relatively low numbers. So what about working with the Foundation Trust Governors? Well, if you go to our website, there's a lot of information there for you, our response to Francis and other guidance, but also, of course, details of how we do the inspections. The framework for the inspections is all there. It's all in the public domain for you to look at if you want to. But we've recently produced a new guide for Foundation Trust Governors, and if you haven't yet seen this, then please do download it from the website at this address, or if you can't remember the address, just go to cqc.org.uk and search for Foundation Trust Governors, and you'll find the page rapidly. On that page, you'll also find extra audiovisual information from other conferences to help you understand what we understand of your role and how we want to work with you. So I do invite you to explore that if you can. As part of our inspections up till now, but going forward, we want to have a meeting with the Council of Governors. We want to hear your views. Now, we want to hear your views as a council. We don't want to hear your views as individual members of the council. We want to hear what the council thinks about the organisation. You're welcome to give us your individual views, but they will carry weight if they are the joint views of your council. So I encourage you to discuss this and bring your joint views to us rather than to see yourselves as individual advocates. We're willing to meet the whole council or representatives of the council, whatever suits you. So very much we can meet you on your terms. And we want your views on the leadership of the organisation as well as the quality of care. We want you to tell us what you think about the leadership of the organisation. And what I put here are some of the questions that we might want to ask you about the functioning of the board. Do you think the board has a grasp on the important quality issues for the trust? And does it make sure that the action is taken to deal with them? I mean, we ask boards When we speak to them, what are the major quality issues? And sometimes we get very mixed responses from different members of the board. And actually the board should have a view. What are our quality priorities? So it'd be interesting to see whether you think that. Do they ensure services are well led? I mentioned the importance of leadership at clinical department level. And are they efficiently run? Clearly, efficient use of resources is absolutely central to successful organisations now. So do they measure, assess and make sure they run their services efficiently? And how do you know they're doing that? Do they promote the right culture? And so that's a culture of learning. In every hospital, things go wrong. Medicine is inherently risky. But do they learn when things go wrong? And do they do their best to make sure those things don't go wrong again in the same way? Do they have a culture that doesn't lead to blame? So when things go wrong, staff don't get blamed, but actually staff are part of the learning. So staff feel empowered to actually report problems rather than scared of reporting problems because of the impact on them. Is that the culture that the board is promoting? Is it a board that wants to hear the bad news, not only the good news? Assurance, which is this great word that you hear bandied about, is not about being told everything is all right. It is being told where the problems are and what's being done about them. And is the board that wants to hear that? Is it focused on safety? And I've spoken already about the importance of the safety culture. Is it focused on transparency? Does it tell you what's going on, or does it keep it to itself? Do you know what's going on, or do you feel the information coming to you is managed carefully so you only find out what they want you to know? Is quality improvement, day-to-day quality improvement, part of the culture of the organisation? And comes back to what I said about listening to staff and, of course, patients. Does the board genuinely listen to the honest voice of staff and the honest views of patients? So there are many ways they can do that. Every organisation, for instance, is obliged to do friends and family, but friends and family is a relatively crude way of assessing patient feedback. We expect them to go beyond that. We expect them to have their own way of assessing what patients really think about their services, not just to rely on the kind of bare minimum. Other things you may want to consider are the fundamental standards. These are the regulations which we operate under, and this is what we expect. Now, I won't go through these in detail. There's far too much detail there now at the moment, but you'll find details on our website. But these are the standards that we hold organisations to account for. So usually if we're saying a service is inadequate, we're saying it is breaching one or more of these fundamental standards. And it is amazing how often we find that. Some of these standards have legal penalties attached to them, such as the duty of candour. And the duty of candour requires a trust to be transparent with its patients. Many trusts are struggling to get that one right. They are struggling to get that one right. It isn't just about being honest. It is a legal duty to tell patients the truth explicitly and to apologise, and to frankly apologise. Okay, I mentioned the staffs earlier on. I could show you lots of evidence about quality, but I just want to highlight this one to you. This staff survey, 2015, the survey was done in September last year. It was published in February this year. It is about the views of staff. It is a very important document. We have found a very close correlation between between the outcome of the staff survey and the quality of care that patients receive. And that is clearly, if you support staff, they provide good quality care. Now, if I was a board member and this staff survey came to me, I would want to do urgent things about it. It takes a long time to turn around the culture of an organisation, but it takes even longer if you never really start. Okay? And so I don't know. If the staff surveys are available on the internet for anyone to see, you just download NHS staff surveys, you'll find your trust staff survey on the internet. It's easy for you to pull it out. But, I'd want to know if this board, for this organisation, and this is just one of the organisations we look at, was taking this seriously. Look, red means that they are significantly worse than the rest of the NHS, and you see for a whole host of questions, including things like bullying, including things like seeing errors, they are worse than the rest of the NHS. So that is something that the board should be looking at and dealing with. So those kind of data that's publicly available, I suggest that you may want to use that in your discussions with board and ask them what they're doing about it. But that's all I'm going to say about it. Just one more last slide. This is where we're going, and this is the future of the CQC. At the moment, we do these very big comprehensive inspections. From 2017, we're going to be moving towards much narrower, focused inspections. They will be predominantly unannounced. We will just turn up on a day to look at a particular core service, because we don't want trust to spend enormous resources in preparing for inspections. And also, we want the opportunity to see things as they really are. We will do occasional comprehensive inspections for trusts we have real concerns about, or perhaps newly set up organisations, but they will be exceptional. We'll ask the trust to provide us detailed information on quality once a year, and we will do an assessment of the trust's leadership, every trust, once a year, and we will revisit the ratings of every trust once a year. So we give trusts to demonstrate that they are improving, because we're very keen for those trusts who have ratings of requires improvement, or perhaps even those who've got ratings of good, to demonstrate they're getting better. And we want to give them the opportunity to do that. But we will do at least one inspection at every trust every year, and that will be one core service. So we will visit on the ground to look at clinical care in every trust every year. As I say, we've discovered that leadership is critical here, so that well-led review will take place every year. And as part of that well-led review, we'll want to talk to you. So that is all I'm going to say, and I'm now going to hand over to you and say, what is your experience, and how would you like to work with the CQC?
My name's Melvin Passmore. I'm the lead governor of the Black Country Partnership Foundation Trust, which is a mental health and learning disability organisation. I wish that I recognised those questions that you had for the governors. We had a very unsatisfactory experience in October where we came into the room and we were asked, what do you think your trust does wrong? Strange way to start. We didn't get on to any of those questions or what the trust does well, and that was the end of our evening meeting. And I suspect that the staff from your organisation wanted to get away quick. That was at the beginning of the process. What we really would have liked would be for your staff to come back afterwards and ask us, we found this, what's your comment on that? So I'd love to see those questions asked in future. The other thing is that when you have an inspection in October, but you don't get a result or a formal answer until about last week, we think that's a bit long.
Yeah.
So, I think there you can make some improvements there.
We'll take a couple of questions.
Well, I'm glad you like the questions I put up on the screen, and I think we can improve on our questioning. So thank you for that feedback. In terms of the length of time reports come out, I think it's important that the reporting back is not a measure of the action of the CQC. We take action immediately if there's a problem. But the reports are very, very detailed, and we are doing reports on every trust in the country. Inevitably, it takes time. We want to get them out much quicker. We agree with you, but our staff are working enormously hard to turn them around at the moment. So I apologise for the delay, but it is really a measure of the pressure our staff are working under in doing inspections on 150-odd trusts, which I think is enormous effort that's taken.
Okay. We'll take a couple of questions, one here and one there, and then if Paddle can come down to the front, the lady in pink here, and there's a lady in red over the other side.
David Bray, Lincolnshire Partnership, NHS Trust. One of the points that gentleman was made was in my question. You take too long to give the answers from your report. That has a bearing on everybody in a very, very good team. Our staff, good team, need to either get the praise or be able to put things right if they're not right. They need to be able to do that straight away. They need to know that they feel valued. And when it takes 6 months to get one of these reports, that's not good. And I've spoken to lots of your colleagues, all junior to you obviously, and they agree that waiting 6 months for a report is not good.
Well, I agree with you, but it's a measure of the pressure we're working under. But just to make a point, if things need improving, we tell the trust about them straight away. So it is not waiting 6 months to make improvements. It is making 6 months for the full report to come out, which is slightly different. But I take your point, and we are working to bring out the reports much sooner.
Okay.
The other thing is to do with finance. A lot of the problems that we're talking about are solved if we had proper finance. When the government turn around and say, oh, I'm sorry, we can't tell you how much your budget is until you're 6 months into the year you're spending, what do they expect? How can people be running safely and smiling and happy when they're 3 months behind with the figures? No, the pressure's being put on by lack of finance.
Okay.
Well, we don't report on finance, and I can't speak for the government, but having said that, we see lots of things in our inspections that can be sorted without extra resources. Some of them do need extra resources. I totally accept that. But some of them can be sorted without extra resources.
Okay, we've made the point a couple of times about the length of time of reports. So if that was your question, can we put that to one side and go on to another area? At the back now.
I'm Frances Blunden. I'm a patient-elected governor at the Royal Free London. I'm very interested to hear your view that the governors have a central role in the CQC inspection. I would have to say, though, that differs from our experience at the Royal Free London, where we did not have a meeting with the CQC separately as a Council of Governors, and there was no attempt to involve us as a Council of Governors. For me, that raises questions about the consistency of approach of the CQC in terms of its inspection, and particularly if the governors are to be regarded as a sort of key part, particularly in the assessment of what's well led.
Okay, well, can
we take a couple more questions, then we'll get through more. Two red ladies. Or pink.
Thank you very much. Dan Whitby, Royal Surrey County Hospital. The CQC really needs to make it clear to the board that it wishes to speak to the governors. I think following on from what this lady... We were given... so I'm sorry. The CQC needs to make it clear to the board that it wishes to speak to the governors, the Council of Governors. We were given 1 hour... we were given a few days' notice of the meeting. We were given 1 hour with the CQC, and the company secretary was present. It's all the board allowed us, and that was, I thought, not acceptable. So I think the board won't do it, or some hospitals won't do it, unless it's made very clear that that's what the CQC wishes.
Okay.
And could I just ask, what does inspected but not rated mean?
Okay, and we'll take one other question over there, and then we'll come back on.
My name is Suzanne Phalke.
Stand up.
I'm an NHS staff member and have worked in Nottinghamshire Healthcare Trust for over 20 years. I'm also a lead governor, which for some of you that might be surprising, being a staff member. But I've listened to what you've said, and I see that your audience are governors, but there are also people here who may be staff members. And it's felt like a whipping from the CQC for a number of years. And what I'd like to say is, on behalf of other people working within the organisation as a staff governor, how do you ensure that the individuals that are recruited to the CQC understand their role and are consistent in their approach when they're on inspections?
Okay, fine. So the issue about meetings with the governors, I think that is, I mean, clearly we need to make ourselves clearer to boards. We do ask boards to set up a meeting with the governors. The meetings that we have are set up by the trust, and we ask boards to set up meetings with a whole host of people, staff groups, etc. And we would always include the governors in that. Now, if in a particular, and I'm sorry about the Royal Free, if in a particular occasion that didn't occur, I think that's regrettable. But what I would say to you in response is, actually, if the CQC's inspection is taking place, then we will ask to see you, make sure that you ask to see us, and there's pressure from both sides. And I think that's really very important. But Okay, so it's question over here. Inspected not rated. Yes, that means that we don't think for that service we have sufficient evidence to come to a rating for that particular question. And that generally is effectiveness in outpatients, where outpatients are so diverse that evidence of effectiveness is actually quite difficult to determine. Although we are working on building up a framework around that as well.
Okay, and then the question which is about how do you make sure people coming have the same standards?
Well, the people who are inspectors of CQC are generally people who've worked as clinical and non-clinical staff in the NHS, okay? And they go through a very rigorous process, and we have some really very high-quality people. And I think they understand their role very well. They are assessed for that, and values of the approach is drilled into them as a very important aspect of it. We do have some specialist advisors who are people who come along who are, if you like, clinicians, active clinicians who don't work directly for the CQC but come along as a specialist to assist us. Now, we assess those very carefully as well, but inevitably they don't work for us, and sometimes they misunderstand their role. So we always take feedback at every inspection, and if people are behaving in ways that we think puts pressure on staff, which is inappropriate, we would ask them to leave or we wouldn't use them again, and would apologise for that. Having said that, giving staff a real whipping, I'm not comfortable with that expression. Most of our reports, a lot of the most important evidence in our reports are what staff tell us. And after a report is published, we often get staff contacting us saying, thank you, at last someone's telling the truth about what's going on in my hospital or my service. And a lot of staff out there are not having their voices heard or haven't had their voices heard until these CQC inspections. And their voices are too important to ignore. So when we say there are problems, we're not saying the staff are problems. Often the staff are the people who are being ignored in the whole process. Sorry.
Okay, 3 more questions. There's one at the back, one here, and one here.
Hi, it's Kevin Watson from Lee Healthcare. Thank you very much for the presentation. It was well taken. The question I've got for you is there a role for trusts where you've got either outstanding or very high quality for the governors to be involved in taking the processes and information back down to other trusts that may be not so well performing in their local area or even regionally?
I think that's an excellent idea. And we do want the outstanding trusts and the good trusts to be part of helping other trusts improve. NHS trusts tend to be very insular, and they see themselves in competition with their neighbours, but actually we see that as an opportunity. So I think if you're part of an outstanding trust and it is really doing well, I think sharing your experience with governors of other trusts who perhaps feel they're doing less well would be very helpful. So I'd encourage you to do it.
Okay, this question.
Lorne Williamson, Deputy Lead from Addenbrooke's, which you rated inadequate, despite the excellent care you rated for the nurses. You came in at a very inappropriate time, just after a complete new system, the first in the country, had been introduced, and you asked people whether they were happy. Well, they're not happy. Change. Nobody is happy with change. You came in at an inappropriate time. You never had anything to do with the governors, and you used your format for evaluating the hospital, which is in medicine, as you showed on your thing, whereas our hospital is management organised on clinical pathways, which you could not cope with. And I wonder whether there is a case for inspection actually doing anything to improve quality. There's quite a lot of evidence to the contrary, and I say that do you consider, or please consider, that excellence is actually the enemy of the good? You put in procedures that we have to follow and remove local flexibility with staffing rotas and so on. We have an enormous financial problem, and the CQC, in my opinion, is only making it worse.
Okay, thank you. Do you want to respond to that?
Well, I think...
You don't have to.
Well, I mean, I think it's a difficult one, isn't it? Because I'm clearly you're disappointed with the report on Addenbrooke's. But we did find real concerns. I'm not going to enumerate those now, but we found real concerns that the trust was not getting to grips with. And, you know, since then, their new leadership has got in place, and the information we have so far is that they are driving rapid improvement. So we will judge it by its response. You say that inspection doesn't drive improvement. Telling the truth about the problems does drive improvement. It's enormously important. And the problem with the NHS, and it's written across the Francis report, as I mentioned, we found it time and time again, is people are in denial about the truth. Addenbrooke's has some really good world-class services, but it also has some poor services. It needs to accept that and move on with the things.
Okay. Can we, if you want to complain about your report, can we leave that till afterwards? Because we've done that a couple of times, so we can get on to something different. Because we want to cover a whole raft. This gentleman here is next.
Nicholas Hurst, North East London Foundation Trust. You're currently in there now, examining us. Last week, we had a most positive meeting of governors. 28 of our 30 turned up for it. Amazing. And we had up to 2 hours with you, with no officers at all present. In fact, they were actually excluded from there. And every one of the governors had an opportunity to express a view, whether it was about adequate staff or whether they liked the chairman of the board or not. They were able to express that view. And and I had 2 opportunities afterwards to talk to your representatives. So I think that was very good. Thank you.
Thank you very much for that feedback.
The point here has to be inconsistency, because in the same room you've had people who've been fully engaged, people who haven't been engaged at all, and people who've had a medium amount of engagement. That seems to me to be something to take away about how do we get consistency.
I think that's an important message for both of us. I need to take it away, but please, you take it away as well, and make sure that when we come round, you have your voice heard.
Yeah. So we'll take a question at the front here next.
Scotty Gregory, Dorset Health.
Can you hold it up a bit towards your mouth?
Sorry. Scotty Gregory, Dorset Healthcare Foundation Trust. I was going to say, don't think I'm a plant, because I was going to say last year we had engagement with the CQC, and it was excellent. They listened to us, they took on board what we said, and they also gave us very good feedback too. But the other thing that I wanted to say is that when you actually drill down into where needs improvement comes, in many instances, it's due to staffing. Do you, in your inspections, make any distinguishing sort of marking between not having sufficient staff because you can't jolly well get them however much you want to, and not having adequate staffing because that's a decision of the board to have that few staff?
Yes, we do. I mean, the board needs to assess the staffing that's necessary in all areas and make sure it's safely staffed. But, as I said, one of the reasons why some trusts are not well staffed is because they're actually not very good places to work and people go and work elsewhere. But there are genuine recruitment issues in some areas, and I think we recognise that is a challenge for organisations. What we ask is, how do they mitigate it? How do they make sure the risk to patients is managed when you can't recruit the staff you need? So do they recruit other staff or manage the service in a different way? What you can't do is just say, there's a risk to patients because we can't recruit staff and we're just living with it. What we want them to say is, we know there's a risk to patients because we can't recruit the staff we need, and this is how we're managing it. This is how we're making sure the patients are kept safe.
Okay, here, front table afterwards.
Hi, Moira Johnston from Peterborough and Stamford Hospitals NHS Foundation Trust. I'm a staff governor. I was just listening to your presentation and you were talking about... Sorry. You were talking about... Oh, God, that's very loud. You were talking about how you've done full inspections and obviously we've got our various different categorisations. If in the future you're only going to be coming in and looking at one particular service where you've already acknowledged that actually sometimes you have a great service here and a poor service there, how will your ratings match up? How will we know that when you finally tell us that we are outstanding, that genuinely that's outstanding across the hospital? We'll know that you mean it about the leadership and about that individual service, but we won't know necessarily that you mean it for the whole hospital.
We would use all the information we've got on the other services together with the previous inspections. to judge whether there's a risk of a problem there. And if we think there's a risk, we'll do another inspection. So we'll inspect one service as a minimum for every trust. We'll inspect more services where we need to come to review. What we're trying to do is create a rolling programme so ratings can change year on year. At the moment, trusts wait several years for us to come round again to have their ratings change, and we don't think that's fair. I mean, clearly there's a risk they may have deteriorated, but we hope that many of them will have improved, and we want to be able them to demonstrate that they've done so. So we're creating a rolling programme, but what we don't want to do is lose that sense of actually finding out what's going on the ground. So we will be coming in and inspecting all the services we need to inspect. Any service that's inadequate or requires improvement is likely to be re-inspected.
Okay. Question here?
Good afternoon, Dr. Ian Sebel, Dorset County Hospital. We had a very good experience with the CQC visit. We were well briefed in advance by the executive, and we were encouraged to ask you questions. Your guys asked the questions which are pretty much in the format you showed. I wonder if governors might be taking back to their boards and their directors that they wish to be fully engaged in CQC reports. It does sound to me as if some of you were kind of pushed off to the sidelines, be good children and ask the questions. Maybe that's for some of you, for you to take back to your hospitals. Second point, do you think that the NHS is still being beaten with the rod of mid-staffs, or have we actually made significant movement in improving public awareness, public appreciation?
I think what the CQC is doing is an important bastion against another crisis, a bit like mid-staffs. You know, obviously a different crisis in a different trust, but actually we're there to intervene before that occurs, and that's really what we're committed to do. I think remembering the crises, and mid-staff's one of the more recent ones, but I mean there have been several over the years, and recognising that the NHS gets into this mindset where it's in denial about problems and they build up until eventually they become a major crisis. We need to move away from that. And one of the ways of doing that is obviously having the CQC there looking out, but fundamentally the way to deal with it is to create a transparent NHS where people are honest about the problems and they don't try and hide the problems. You know, and I think part of this interaction between boards and foundation trust governors, which you were just talking about, is really very, very important. I mean, do you as governors feel that you know what's going on, and do you feel you're being told the truth by the board about its concerns and what it's doing about them? Or do you feel you're being given a message that is being carefully filtered just to keep you happy? And I think, you know, that's an important question. And when we talk to governors, that is really what we're trying to get a sense of. Do the governors feel confident they know what's going on, and are they confident the issues are being dealt with?
Okay, we'll take two last questions, the yellow and then the red.
Hi, Paul Murphy, Moorfields Eye Hospital. Could I ask, could I ask, how do you train your staff, and can you give us any assurance that they're not comparatively judging us? They're going in and judging us by absolute standards. In that, you know, if they've been to a very good trust the week before or a very bad trust the week before, they haven't still got that in their head when they're comparing. They're doing it by an absolute standard. And secondly, you talked about honesty and transparency. A particular trust might have very, very high internal standards, and by their own internal standards, they might not rate themselves outstanding. They might rate themselves as only good. But you know, I, as a governor, might want to tell you, we want to be outstanding, but we're probably only good because of this, that, and the other. My fellow governors are going to turn around and say, "Don't tell them that. They're about to give us an outstanding." We want to be honest and transparent, but we don't want to, over-influence your judgment. I know you're going to speak to all the staff and get a collated view, but you could answer those two.
Yeah, well, that's fine. We're coming to Moorfields soon, I think, aren't we? So I can understand your concern. I mean, Moorfields will be a challenge to us because it's a specialist eye hospital, and I think it's the only specialist eye hospital. And we have actually gone through quite a detailed process of preparing for that, bringing in eye specialists from all over the country to explain what we should be looking for. So the training issue, in the technical terms of the training, is, I can reassure you on that. I think in terms of the attitude, we judge against absolute standards. We don't. It isn't a comparison. We're saying this is how you perform against the standards. We will ask the trust to rate itself. But we ask the trust to rate itself not because we're going to kind of, if you like, use that to influence our rating, but so that when we get our rating, we have a sense of how realistic the trust is about itself. So if you said you think it's outstanding and your colleague says no, it isn't, don't think that either of you are going to have an effect on what we judge. But we will kind of say, well, that chap's got more insight than that chap at the end of the day. But, you know, that's that way part of the report. Okay? But we'll ask the board to say how it rates itself. And, you know, to some extent, if the board gives us a realistic rating, where it's honest about its problems, but, you know, proud of what it's doing well, which we want to see as well, then that's what we want to see. What we don't want to see is a board that, if you like, tells you everything's outstanding without really seriously looking at the evidence.
Okay, and the last question. Sorry for people who haven't had a chance, because there's lots I want to ask, but we need to move on.
David Bowater, Councillor David Bowater. I'm a local authority governor at...
Can you lift the microphone?
Yeah.
Yeah. Okay, we'll swap microphones.
Hello, I'm David Bowater. I'm a local authority appointed governor at South Essex Partnership Trust, also an electronics engineer, which explains why. You were very dismissive of the fact that CQC don't have any controls over costs. Let me say that today I came here on a bus from my home to the station, second-class rail to Euston, and I even got a 1/3 discount on that because I have a senior rail card. Now, how do you square that with reports we are reading in the press that one of your inspection teams on a very small hospital inspection in Norfolk ran up a bill of £115,000 by staying at a 4-star hotel which had a 3 Michelin star restaurant?
Well, I have to say we don't recognise any of that, and a lot of what. Just let me answer the question, please. We don't recognise a lot of any of that, and a lot of what we read in the newspapers and similar journals, where people have kind of taken a number of inspectors, multiplied by some fudge factor, and come up with a spurious figure. It bears no relation to the reality at all. Our inspections do cost money, inevitably. They are big inspections. One of the reasons we're moving to a different approach going forward is to try and make ourselves as efficient as possible, recognising we spend public money. But the inspectors, when they're on inspection, work long days, they work very hard, and they are not put up in luxury accommodation. That is absolute nonsense. And I think you should be careful about what you believe in the newspapers.
Okay.